You'll actually see this is well aligned with the work groups of the HIT Standards Committee. Clinical operations, first part is medication management. There's a whole set of activities that include all of the aspects of issuing ambulatory prescriptions, querying for history, formula and benefit information, fill status notification, all of those medication activities. There's a set of activities around the exchange of clinical data. So specifically, we've done both structured and unstructured documents. Now, I try in my role as a facilitator at HITSP to do a lot of listening, and I take input from all of our various stakeholders. Some have suggested that we can't enforce very structured data exchange as part of meaningful use tomorrow. Now, of course, we all want to get to highly structured, vocabulary-controlled data exchange, but hey, if a doctor was able to get a discharge summary a few seconds after the patient left the hospital, and it was a blob of text, wouldn't that be helpful? And the answer is, of course it would be. It may not be semantically interoperable or good for quality measurement or decision support, but it's certainly good for continuity of care. So there's a set of constructs, services for both structured document exchange with problems, meds, allergies, labs, discharge summaries, op notes, H&Ps, consultation notes, referrals, etc., as well as unstructured documents, the free text that exists in so many of our electronic health records and hospital information systems today. We also know that it's important to make sure that PCPs and the medical home communicate to specialists, so a document for referral request and coordination between PCP and specialists, have a set of services for that. We know decision support is important, and there's increasingly external providers of decision support services. How is it that a clinician in their EHR can retrieve medical knowledge, either that is human readable or computable, so we have standards for that. Then there's a whole set of standards and services around laboratory and imaging data exchange, which would include laboratory orders and resulting, pathology orders and resulting, microbiology, all the text-based cytology, pathology, as well as those that are defined in a granular way, like the lab numeric result or microbiology organism. Imaging information and its transmission from place to place. Then there's a whole set of constructs around quality. Now, we know quality exists, of course, measurement in many forms, but we've divided it into hospital-based quality information collection and reporting and ambulatory measures, and so a set of data constructs for transmission in support of the HITECH activities. We've also come up with some public health-related and population health-related services, specifically around immunization registry updating and querying, so a lifetime immunization record is available. Communication of immunization documents, so that there is no question what vaccinations you have received, and also if there are supplies of vaccines that need to be distributed, some aspects of inventory management around vaccine and medication. For public health case reporting of infectious disease from emergency departments and hospitals, we've created a set of constructs for that. For emergency notification in the case of mass casualty disaster and emergency transmission of secure messaging. And biosurveillance, we've leveraged the work that has already been done at CDC on their FinMS activities and wrapped it as a service. For resource availability, we know in mass casualty incidents you'd like to know what hospitals are available, what beds can be occupied. And there's a set of administrative activities we've also provided services for, specifically around benefits, eligibility, referral authorizations. And finally, provider directory information. Now, we have embedded in some of these clinical exchanges the patient query of identity, but we also needed a general provider directory service. So all of these services now no longer are buried in an interoperability specification. They're published as 22 capabilities that can be drawn on for any purpose by an EHR, by a PHR, by an HIE, by the NIN, and they do support the idea of point-to-point data exchange, network-based data exchange, and national network data exchange with networks and subnetworks. You can use these services in any of those architectural constructs. So thus, publishing these in an electronic form that enables the HIT Standards Committee and its work groups or vendors or other stakeholders to get at these in a much more accessible fashion has been the work of the last 30 days, and we'll be continuing that over the next 60 days as we wrap up all this work. So just very briefly on some of these, we have tried to, as I mentioned, make this architecturally neutral, so to at least publish a framework describing how these various constructs and capabilities might be used between two stakeholders like a hospital and a doctor's office, or in a local HIE, or in a context of a national health information network that is talking to a networks of networks. So we've got a whole framework for that. We provided electronic implementation guidance with detail that's granular enough so that when a standard is chosen from, say, a standards development organization, we've constrained it enough that an implementer in an unambiguous way can go forward with a set of actual software implementation that is going to be as close to plug and play as we can make it. I've also mentioned the idea that we have published value sets. We're using the AHRQ USHIC tool, the United States Health Information Knowledge Base. You'll find that online if you search Google for USHIC. All of our value set constructs, so these are the gender, the problem list, what vocabularies exactly we want to use to achieve that semantic interoperability, are all available online through USHIC. We've also tried to publish excerpts of standards and, where necessary, do provide links to the Standards Development Organization's specific documents so that our electronic publishing construct is maximally useful. It doesn't require that you have to go to dozens of different sources to get an interoperability specification. Instead, it's one location for the standards, their implementation guidance, the value set, and pointers to any SDO products that you need. This just gives you a sense of the kind of richness of the electronic resources that we're developing, so that we do include standards, all of the various constraints of those standards, the various guidance for implementation, the specific semantic interoperability value sets, publication of how to use these services as I've described them, and the various conformance testing that one would use. NIST, for example, will be a very important partner in all of this activity going forward, because it is charged with making sure that all the publications, all of these accepted and recognized standards that we have in the past put forward are usable, actually work, do what their intended purpose would suggest. I just mentioned here that we have now really tried to take all of the work of the past and place it in this new constructs, including the work HITSP has done, the work the NIN has done, and tried to leverage NIST's activities in testing. So just to conclude, what I hope you've seen over the last 60 days and now going forward for another 60 days, that HITSP has been able to redefine its work to become HITSP 2.0 in support of Healthcare IT 2.0, which I think meaningful use and the 8 constructs in ARA will give us all a great body of work between now and the end of the year, and that I hope all of this activity of NAHIC, the HIT Policy Committee, and the Standards Committee is informed by these various new HITSP constructs. I look forward to your comments and to your questions. Jonathan and I next week will be co-leading the HIT Policy Committee work groups, and we have provided HITSP staff and HITSP volunteers to each of those work groups to ensure that all these 22 constructs I've described today are well described to those work groups, and the work groups can decide if they are meaningfully useful and if they are informative as we go forward to support ARA. Happy to answer questions.
John, that was just terrific, and we're grateful for your leadership and that of the other members of HITSP for all the work that you're doing. It looks like you need to get done by July 15th.
Yeah.
The world we live in now. Well, members of the board, we certainly invite any questions that you may have, and we'll begin with Steve Ruberg.
John, thank you very much for your presentation. I applaud the move away from the use cases to the construct that you described here. The one question I had is around the normalization of vocabularies and value sets and the use of USHIC, et cetera. Is there anything in your thinking about more open collaboration or mass collaboration kind of tools like I see with Wiki HIT, where people can contribute content? And is that a way to surface more content or have more collaboration in an open format to help build vocabularies, data elements, valid value sets, and things along those lines? Has that been discussed, thought about, or do you see that as a viable way to surface the content that's sitting in so many companies and institutions as a way for harmonization?
Right. No, I think that's a very rational evolution of what we're doing. Our first pass has been to try to take federal medication terminologies and the work that had been done in federal health architecture, the work that has already been done in the National Library of Medicine, and try to at least harmonize that set of constructs. But to your point, and again, with ePatient Dave and I, we look at SNOMED. SNOMED has thousands and thousands of terms, but of those thousands of terms, which are the ones that doctors actually use most frequently in the context of a problem list? Oh, well, actually about 6,000 or 7,000 of those terms. So NLM, in effect, did the process you described. They brought together folks from Regenstrief and folks from Kaiser Permanente and folks from the VA and have constructed what they consider is a 6,000 or 7,000 term list that represents a good best practice for a subset of SNOMED as a problem list. So I suspect we'll do the initial publication, and then through this kind of mass collaboration, we'll get refinement as to what is really useful.
Lori Evans.
Good morning. Great presentation, John. I have sort of 3 quick questions, if that's okay with everybody. So the first is just following up on your comment about the work of the past and really placing it into a new contract. How much to date really is new work versus just taking lots of things and putting it into this new contract? And then how much will be new work between now and December? That makes sense. Then the second question is, in this sort of evolution of HITSP 2.0, how has HITSP had a chance yet to think about how it will maintain this services contracts, which I think is terrific, and then also maintain a set of real protocols that will allow the services to really talk to each other? And has HITSP 2.0 thought about how it's going to do that? And then third is, if you could say a little bit more on the relationship between HITSP 2.0 and the Standards Committee.
Great. Excellent questions. So this represents a reformatting and a simplification of the existing work. It's not new work in the sense that we aren't declaring new standards. So we know that there are several administrative processes that would be required should we decide, oh, here's a completely new standard, it's June. So we've said, oh, we've already used what are accepted and recognized standards constructs. These are published in the Federal Register. So let's just go through 7,000 pages of documentation and pull out those standards that are now part of these 22 separate constructs. They're all existent. Now, I think, and working with the HITECH folks, there may be some novel work around quality that we'll do together, but basically it's leveraging what we have done in the past. Now, maintenance, this is an absolutely key point. How was it that we developed interoperability specifications based on use cases and value cases? The answer was really smart people got together and we created this document. Oh, this document uses a problem list. oh, but wait a minute, that document we did last month also used a problem list. What we had in the interoperability specs was sometimes contradictory advice because of the nature that the way that the interoperability specs were developed as use cases. So going forward, because it's fully electronic and it's based on function and services, there's one way to do a problem list, which means there's one way to maintain a problem list construct because it's all electronically published, a single pointer by service and function. So we are looking at this as not only a radical simplification of everything we've published in the past, but ease of maintenance has gone up.